Here at Arvo, there's going to be, and there has been in other previous meetings, a lot of sort of case series recall of people who are on Avastin or Lucentis being switched over to Eylea. What's sort of the general summary of how those patients do?
Well,
No, go ahead.
So our superstar resident, Kush Baggarwal, she's a resident in Mass in New York, New York for fellowship. She spearheaded a study looking at 35 patients at our center who we could not treat and extend beyond 6 weeks with Eylea, with Lucentis or Avastin, and switched over to aflibercept. And what we showed was an improvement in vision, drying on OCT, and looking at VFQ-25, an improvement in the patient's perception of their disease, mainly driven by decreased visits. But I just for fun, I looked at 15 different Arvo abstracts that are presented here at Arvo at this meeting, and just to qualify it, there's great variability in the studies. Who are included, how suboptimal responders are defined, inclusion, exclusion, how they were imaged, but they all included suboptimal responders to Lucentis or Avastin. And this is what I took from it. There are 15 abstracts. Only one single study showed that vision and OCT did not change. Okay, 3 studies showed that vision didn't change, but OCT improved. 1 study showed that vision improved, but OCT stayed the same. But 10 of the 15 showed that vision and OCT both improve. Now, you have to be very careful what you derive from this, but the key message is that no one had a decrease in vision or a decrease in OCT. So I think if we switch to aflibercept from older generation anti-VEGF, we can do so safely. And there is a distinct population of patients that do respond, who knows why, whether it's placental growth factor, tachyphylaxis, all sorts of reasons, or maybe higher binding affinity to VEGF. But I think we can do it safely, and maybe even have benefit in terms of dosing regimen.
Yeah, I think, looking over, as Sinu said, there was a wide variability of the type of studies that were submitted. By far, the vast majority of them are retrospective. And so drawing any sort of significant conclusions from these, I think, are difficult. We're right now doing a prospective study that we're looking at the Cleveland Clinic that one of my partners, Rishi Singh's running, and we're starting to learn some of that data coming out of it. But what I saw as sort of the unifying sort of commonality of these is that anatomic improvement. That seemed to be pretty universal. And the vision was a little bit more variable as I looked at them, but again, when you go retrospectively, it's so difficult to interpret that because you don't know when is the starting point. Were they going from PRN dosing to regimented Eylea? But the clear commonality that I saw was that the anatomic change was pretty distinctive. There was one study that actually, I think it was like 80 eyes, and then they looked at the subset of 12 eyes that lost vision when they first changed. And of those 12, the bulk of them actually came back to baseline. There were 5 that didn't, but every single one of the 12, I think, improved from an anatomic standpoint, which probably lends itself to the chronicity of the disease and is probably actually, and I've had these patients, one of the things that when you talk about switching I'm always cautious about is, they have this little tiny bit of subretinal fluid and you flatten them out and their vision goes down. My hope is at that point the vision stays stable because you've now hopefully stabilized the disease, but clearly it seemed like in the bulk of these abstracts the anatomic change was there.
And the study he's talking about from the Cleveland Clinic, Rishi's study, we prospectively followed, I think it's about 26 patients that were enrolled, and we put them onto a fixed dosing regimen of Eylea, 3 injections after switching them, and then every 8 weeks. And at the 6-month time point, the patients gain about 7 letters of vision, which is, you don't expect to see such a large improvement in such a short period of time. So.
And especially the hardest to treat patients.
Right. Yeah, exactly.
Chronically treated patients, exactly.